Hello, everyone, and welcome to the Multiple Sclerosis Association of America's live webinar, Helpful Tools for MS Relapse Management. My name is Peter Demiri. I am the Vice President of Programs and Services for MSAA and will be your host for tonight's program. I'm looking forward to having a great presentation and very honored to have a top MS expert here tonight to present on MS Relapse Management. At this time, I would like to introduce our guest presenter, Dr. Elizabeth Crabtree. Dr. Crabtree is Associate Professor of Neurology and Vice Chair of Clinical Programs at the Tulane Center for Clinical Neurosciences, Medical Director of the Tulane MS Center, and Course Director for Brain, Mind, and Behavior. Dr. Crabtree is also a longtime healthcare partner with MSAA and co-chair of our Navigating MS initiative. Dr. Crabtree, thank you so much for being here and welcome to the program.
Good evening, everybody. Thank you so much for the lovely introduction. It truly is my pleasure to join tonight. MS care is something that really means a lot to me in terms of taking care of the whole person rather than just targeting the immune system. And I can already see some hands raised with questions about things besides disease-modifying, what can we do? And I'm really excited to see that interest. Yes.
I'm sorry. I just wanted to advance through a few more slides, and then I'll turn
it
over to you.
I'm so sorry.
No,
I'm so sorry.
not at all.
Thank you for inviting me.
Sure. I'd like to thank the supporter of tonight's program. Tonight's webinar, along with other activities during MS Relapse Awareness Week, is made possible through an educational grant from Mallinckrodt Pharmaceuticals. And I just wanted to take a moment to touch on MSAA's programs and services. As many of you may know, MSAA's mission is to improve lives today, and we do that through our free programs and services. Listed here are just some of the many services we offer to the MS community. And since tonight's program is on MS relapses, I want to highlight at the bottom our online MS Relapse Resource Center. This website hub has a wealth of great information in print and digital, including our latest publication, the MS Relapse Toolkit, which is a great resource to help better understand and manage relapses. And this can be downloaded as a PDF or ordered for free online. So I encourage everyone to give us a call or jump on our website at mymsaa.org to see how we can help your needs. And just a quick note on tonight's webinar itself. So as Dr. Crabtree mentioned, we already have questions posted, which is awesome. So in that chat box, you can post the questions that you would have like to have her answer. I will be throughout the program jotting these questions down, and I'll collect as many as I can. And we will put them out to Dr. Crabtree at the end. We'll try to get in maybe 10, 15 minutes of the program and try to get as many as we can answered. At the end of the survey, at the end of the program, we have a survey. If you can take just a few seconds to complete and fill out to help us hear about this program tonight and future webinars we would do on different topics, MS. And also, for the technical part, if you're experiencing any technical issues or have a question of audio or other issues on the screen, please use that same chat box and a moderator will respond back to you. And just a note that tonight's webinar will be archived and put on MSAA's website, mymsaa.org. So without further ado, I would like to once again introduce Dr. Crabtree as our presenter. Thank you.
Okay. Thank you, and I'm so sorry that I interrupted you earlier. Tonight's objectives, I will define relapse or exacerbation. Those are synonyms in this setting, and how they differ from what's called a pseudoexacerbation. I'll describe the risk factor for relapses so that we can understand what we have control over and what we don't. So how can we maximize reducing our risk for relapses? And then if a relapse does happen, what are some treatment strategies for relapses as well as for pseudoexacerbations? I did want to say that what I started to say earlier, which is although the focus is on relapse, I really want people to recognize that it's within the context of whole person care. And I'll highlight that a little bit later in the presentation as of course, my dog just took out a squeaky toy. Hang on one second. I'm so sorry. I'll go into, come here, Leo. I'll go into maximizing all the components of care a little later in this presentation. Okay. Let's walk the dog out of the room. Sorry about that, folks. So just briefly, I'm sure there are people with various histories joining us tonight, and some people might be relatively new to the world of multiple sclerosis. For some, this is going to be review. Just briefly, I want people to understand that there are different forms of MS and different personal experiences with MS. I won't go into this in too much detail, but I want people to understand that there's a basic division between relapsing forms of MS and progressive forms of MS. The two can coexist, and then it's called progressive relapsing. But suffice it to say that tonight we're going to talk about the forms of MS that include relapses. And I can see that this, I'm not sure if folks can read this slide, but the bottom let me see how I get a pointer up here. This might be a pointer. There. Can folks see that green pointer? So down here, this fourth one, I just put a green pointer next to it, represents relapsing remitting MS. And our axes are time and symptoms or disability. Classically, relapses are characterized by neurologic symptoms that develop over days to weeks. They typically stabilize in terms of severity, and then they're followed by some degree of recovery. It's very common early in MS to experience complete recovery, and it's common later in MS to experience incomplete recovery. Obviously, relapses in and of themselves are unsettling, can have a significant impact on quality of life, can have an impact on your work life, your family life. So in and of themselves, we want to avoid relapses. Relapses followed by incomplete recovery, of course, can leave folks with more symptoms to manage or more disability to navigate. So obviously, relapses are something that we would like to minimize. There are some forms of MS that are devoid of relapses. So second from the bottom here is primary progressive MS, wherein a person has slowly increasing symptoms over time. And usually that it regards walking and balance, almost always. So slow decline in walking and balance that continues unabated pre-treatment. And now, of course, we have interventions to help people stabilize. One of my problems with these charts, which are similar to the charts that you see around, is that none of these show a person with maximized management who stabilizes and or starts to improve. The main point that I want to highlight is that the relapsing forms of MS are the forms that are characterized by having relapses, and that's what we will be discussing tonight. Know that not everyone with MS has escalating disability over time, and we can stabilize many of our patients now. So what causes the symptoms? So here I'll talk about some classic relapse syndromes. But what actually causes the symptoms? Well, we think that MS is an autoimmune disorder. And when our immune system is functioning appropriately, it targets non-self entities. So in general, those are bacteria, viruses, maybe fungi, but also your own cells that are kind of misbehaving. So precancerous cells, when they start to divide aberrantly or erroneously, it's really our immune system that governs over that to decrease our risk for cancer. So we call it immunosurveillance, and it's immunosurveillance over infection and over what I would call aberrancy. We don't really know why the immune system is misguided and attacks the central nervous system in multiple sclerosis. In other autoimmune conditions, there are different targets. For instance, in lupus or systemic lupus erythematosus, SLE. In lupus, the target is double-stranded DNA. And as many of you probably know, all of our organ systems have double-stranded DNA. So unfortunately for our lupus folks, they can have symptoms due to an impact on the heart, the lungs, the kidney, the GI tract, the skin. So in one sense, in MS, the target is much more specific. The central nervous system is defined by the brain and the spinal cord. And there's a question from someone regarding optic neuritis. Interestingly, the optic nerve is technically a peripheral nerve, but the casing around it, the myelin, is of central origin. So the cells that make myelin in the central nervous system are oligodendrocytes, and oligodendrocytes make the myelin for the optic nerve. Inflammation from the immune attack affects the myelin and can cause damage called demyelination. And sometimes the symptoms come from where the lesion is, and sometimes we actually can't explain it very well. So as I mentioned, the pathology can include demyelination, and historically we were really aware of white matter lesions. I'll show you a picture in a minute of gray matter lesions. Excuse me. When you hear the term gray matter, so I'm going to bring a gray arrow over here to this MRI. See over on this MRI that's labeled T2 flare, see on the outside how it looks brighter, and then underneath it looks dark gray? The colors are actually inverted here. The brighter outside ribbon is the gray matter, and the darker gray underneath is the white matter. In the gray matter, there are cell bodies for brain cells, nervous cells called neurons, and they project these long outreaching cable-like structures called axons. The axons function like electrical cables, and they function best when they have, just like electrical cables, when they have insulation. The white matter is called white matter because if you look at a brain, either during brain surgery or at autopsy, the myelin, so the insulation, is what makes the white matter appear light or white. Sorry, I'm just getting over that weird cold that's going around. Unfortunately, in addition to damaging the myelin, we can have damage to the axons themselves. Sometimes there's normal appearing white matter. So for instance, here's an area where there are no bright spots or lesions. So these bright areas are called lesions or plaques. Where you don't see them, that's normal appearing white matter. And actually, MS can cause changes in normal appearing white matter. It's one of the cruelties of multiple sclerosis that in addition to affecting the myelin, the immune attack also affects our ability to heal and replace the myelin. So I just mentioned that the cells that produce myelin in the central nervous system are called oligodendrocytes, and the oligodendrocytes themselves can be affected during an MS attack. Also, in all of the systems in our bodies, we have on and off switches. So you can imagine that in normal development, you don't want myelin to just be produced without any checks and balances. You basically end up with tumor-like collections of myelin. So the signal or the protein is called no-go that tells the oligodendrocytes to stop making myelin. And unfortunately, during an MS attack, that signal to stop making myelin is upregulated, meaning it's more active. Actually, let me say one more thing about this slide. I'm so sorry. Let me clear my throat definitively. Hang on. Let's see how that one worked. During an MS attack, the immune system will cause the areas of inflammation that are bright. You can see them as bright areas on FLAIR, which is a T2 image. And then the image on the right is called a T1. And when we give contrast, so this lesion is taking up contrast, an MS plaque, when it's freshly formed, will take up contrast for about 6 weeks. So when I look at this scan, if I had a date when the patient got the scan, I could tell you that the person's MS was active and was actively causing inflammation sometime in the 6 weeks leading up to the scan. So during an MS attack, we see evidence of inflammation on brain imaging. As I mentioned, white matter lesions, the bright areas we just looked at, are what we focused on relatively recently with the development of stronger magnets. So this is a 3 Tesla MRI, traditional MRI, what most of you have probably had, and this is a 7 Tesla MRI. So here, what we can see, which we would never have been able to see on a 3 Tesla, where my green arrow is a classic gray matter lesions, a classic gray matter lesion. And so, like I mentioned, the pathology, there's demyelination not only in the white matter, but also in the gray matter. And we can appreciate that on neuroimaging now. Sometimes, if you come in to see me and you tell me what your symptoms are, I can say, I think your MS is affecting this particular part of your central nervous system. Or conversely, if we're in my office and we're looking at your brain MRI, you might point to a lesion and say, which symptom is this causing? Sometimes there's a very straight correlation. And there are parts of our brain that are very good at compensating. So, for instance, these MS plaques are mostly asymptomatic. So most of these lesions, the patient isn't even going to feel them. However, when the lesions are in other places, so the optic nerve, the brain stem, the back of the brain called the cerebellum, or in the spinal cord, pretty reliably a person experiences symptoms. So when the optic nerve or the nerve sheath, the myelin sheath is affected, it's very common for someone to experience blurry vision in one eye, decreased vibrancy of color in that eye, particularly in the red spectrum, and pain behind the eye that gets worse with eye movement. Now, I say blurry vision, but in our support group, people use different language, and obviously people experience things differently from one another. But so other descriptions are things like water on a windshield, pixelated like the face of an ex-con on TV, smeared like Vaseline on a lens. So, in medicine we have a habit of putting things in a little box, and we call it blurry vision. But if you experience something that you don't consider quite blurry, just use your words and try to describe it. One member of our support group, who everybody in our support group is lovely, but one member saw, I think it was 9 neurologists before she was finally correctly diagnosed with optic neuritis, and she really felt like part of it was that they weren't really listening to her. She's the one who used the term pixelated, which is one of my favorite descriptions. But I apologize for the language of medicine. All I can say is that by using your descriptions, it helps us to understand all of the different kinds of experiences people can have. So optic neuritis, the brain stem is in the back of the brain. In fact, you can see part of it right here. This is a side view. So this is the person's chin. This is the back of her head. And if you sliced her down the middle and looked at the profile, you would see this image. So you can see here the vertebra. This is vertebra, cervical level 1, 2, 3, 4, 5, 6, 7. So above this arrow is cervical cord, and below it is thoracic cord. If you look at the bottom of the skull, there's a big hole called the foramen magnum, which means big hole in Latin. And above the foramen magnum is the brainstem. So between my two arrows, you can see part of the brainstem. You can see the part called the medulla oblongata, which I personally think sounds like an album by the Police. But suffice it to say, it's one of three levels of the brainstem. It depends which level the lesion. It depends upon which regions of the brainstem are affected by MS. But one can experience double vision. A very characteristic MS syndrome is called INO, or internuclear ophthalmoplegia. And what you'll experience is double vision that gets worse when you try to look close to you rather than looking at street signs far away. It's when you try to read, or when you try to set the table, or you're looking down at your hands. And it'll be worse when you look to one side. It's because one eye does not move towards the nose. So double vision is a common symptom. Weakness or numbness affecting the face, arm, leg, torso. The cerebellum, if you've ever seen a cop show where they do a DUI testing, or you've been to a neurologist and you wonder, why do they check some of the same things that I associate with drunk driving or DUI testing? It's because alcohol affects the cerebellum and MS can affect the cerebellum. So in both situations, you can have unsteadiness of gait, room spinning, falling, and then a tremor, not like the kind of fine tremor that you get if you drink too much coffee, but what we call a large amplitude tremor. So it's a cerebellar tremor looks really different from other kinds of tremors. The spinal cord, I want everybody to take your right hand and look at your right pointer finger. Okay, see how wide that is? Not very wide, right? Like I'm looking at mine right now, and it's probably 1 centimeter and a couple of millimeters. So let's say 1.5 centimeters maybe. So all of the information, sensory information from my feet, legs, trunk, arms, face is all going up to the brain, to the sensory cortex, and all of my commands for movement to all of those body regions are coming down. And all of that traverses the spinal cord in that very narrow arena. And our bodies are not good at compensating. And so with a spinal cord lesion, sometimes they're silent, but not very frequently. And classically, spinal cord syndromes will start in your feet with numbness or feeling of heaviness, thickness. One of my patients described it as feeling stuff like cotton, like Mickey Mouse feet. And it starts to climb up the leg. Often it goes all the way up the leg and then settles somewhere in the torso. Sometimes it settles at a level and it's associated by a tight feeling, almost like a belt or a cinch. And then people can have muscle spasms, muscle tightness. Bowel and bladder, we can see incontinence, but it's much more common that with bladder we see urinary frequency and urgency. And with bowel, it's more common to see constipation. So these are four examples of syndromes that I can tell you with relative confidence why you're having certain symptoms. Other symptoms we just don't understand as well. So fatigue, I can't point to your MRI and tell you why. Same thing with depression, cognitive changes, and then sensory integration disorder, I'll describe in a minute. As we learn more about gray matter lesions and other measures of pathology, I'm hoping that our understanding of especially fatigue, actually all of them, fatigue, depression, cognition, they're all so challenging for people. But I'm hoping that as we figure out ways to look beyond the white matter plaques, because that's what we have to do in MS. We have to continue to understand the white matter plaques, and then we have to look beyond the white matter plaques to really understand why you're having the experiences you're having. briefly, sensory integration disorder it is described in various ways. But for instance, if you, and some of this, by the way, happens to people who don't have MS. So if there are folks on the line who are being worked up for MS, what I'm describing is not it's diagnostic of MS. But people can experience more difficulty driving because the moving imagery in their peripheral vision feels overwhelming or hard to process, whereas they used to do it without even thinking. It can manifest as having real difficulty being part of a group conversation. If there's more than one person talking at once, it can feel very overwhelming. Visually, similar to the first example, people describe walking in Costco and feeling almost dizzy or overwhelmed by the shifting colors in their peripheral vision. So sensory integration disorder, sometimes it's associated with optic neuritis. Sometimes it's associated with what are called occipital white matter lesions, but often it's not as specific as the 4 syndromes I described just a minute ago. So if we think about the spectrum of MS, and this slide was made by Dr. Darren Akuda, who is now at UT Southwestern. He and I were at UCSF together for years, and the slide is being used with his permission. If you think of the spectrum of demyelinating disorders, and this is the beginning and this is post-mortem, we know that some MS is never causes symptoms. So you technically can't call it MS, but suffice it to say that on autopsy, a measurable percentage of people who are quote-unquote healthy without neurologic symptoms will have classic MS changes, classic MS plaques. So we know that some people have quote-unquote asymptomatic multiple sclerosis. We now catch people while they're still alive with asymptomatic multiple sclerosis. And I want to qualify that I'm calling it asymptomatic MS, but just know that you cannot be diagnosed with multiple sclerosis if you haven't had a symptom yet. It's just part of our diagnostic criteria. There has to be one clinical event. I think that in our time together, that definition will change, and we will diagnose MS radiologically. Currently, we do not. One second. Katie, I'm on a... Okay. Sorry about that, folks. My daughter's corkboard fell without explanation. We're convinced we have spirits here in New Orleans. So we now catch people who are asymptomatic radiologically. So, for instance, this MRI is a side view. You can see the teeth here. You can see the nose here. This is the back of the head. So this is like you're looking at someone in profile, sliced right down the middle. And this bright area, the big one, is supposed to be there. That's called a ventricle. But these radiating ovoid areas of brightness are classic MS plaques. They're called Dawson's fingers when they come out, when on side view, sagittal view, they appear radial like this. And this person has never had a relapse. She's never had a symptom. So in that setting, we diagnose radiologically isolated syndrome. So that's a person who has diagnostic, or technically not diagnostic, but then the person has characteristic changes on imaging suggestive of multiple sclerosis, but has not experienced a relapse yet. When a person has one relapse, we call it clinically isolated syndrome, and one of the questions is about optic neuritis with a normal MRI. So optic neuritis with a normal MRI is clinically isolated syndrome. The risk for relapse also depends on your MRI. It's great that your MRI was not characteristic for MS. That makes your risk considerably lower. for having another relapse. However, you are at risk if your spinal tap was negative, your risk is about 9%. And if your spinal tap showed oligoclonal bands or inflammation called IgG index increase, then your risk can go up to 27%. So clinically isolated syndrome is when a person has had one episode, one clinical episode, and the MRI does not have changes suggestive of multiple sclerosis. So we will talk in a minute about relapse. So obviously between radiologically isolated and clinically isolated, that transition is defined by a relapse. And from clinically isolated to multiple sclerosis is defined by a clinical relapse or a change on MRI. So what are some risk factors for relapses? What are risk factors for MS in general? What's the risk what gives us risk going from radiologically isolated to clinically isolated? What gives us risk for going from clinically isolated to relapsing and remitting? Who has a higher relapse rate in general? And like I said, what are the things that we can change? So in terms of why does MS happen in the first place, I wish I had a really succinct response. And the model that I'm going to talk about will be updated soon, incorporating information from the microbiome data that we're collecting. It's very exciting and a categorical shift in how we think about things. However, for tonight, I want people to think about a complicated process, a perfect storm, if you will. Of course, it's an imperfect and unfortunate storm, but genes don't explain MS alone. Infection doesn't explain it alone, and neither do environmental exposure. But there is evidence for a genetic predisposition. As siblings become more genetically similar, their risk for what's called concordance goes up. So if one sibling has MS, what's the risk that that person's brother, sister, or non-binary gender, what's the risk for the sibling? And if you look at siblings, non-twin versus fraternal twins versus identical twins, as the siblings become more genetically similar, the concordance risk, the risk for the other sibling developing MS, the concordance risk goes up, which would suggest that there is a genetic component. However, for identical twins, the concordance risk, so twin A has MS, twin B, normal exam, normal MRI, no neurologic symptoms, the risk for that other twin, identical twin, is only 33%. And of course, if it were a strong genetic syndrome, you would expect that number to approach 100%. So we know that there can be a genetic component. Most MS is sporadic, and I'll answer specific questions if there are at the end. I want to make sure we can get to cover everything and everybody can ask her their questions. It's her there. Infectious exposure. Let me just see. Hang on. Oops. Uh-oh. For some reason, my slide's not exam. Oh, wait. My slide is not advancing. Let me see.
Want me to try it, Dr. Crabtree?
Yeah, could you? I think it's because I activated this red button. Let me see if I can deactivate my red button. Let's go back to this. Yeah, a network connection. Oh boy, if I lose you guys, I will. Let me.
Well, can you see the slides? I advanced to environmental risk factors.
Hang on, because it's my network connection, I'm stuck on etiology. Just give me 1 second, guys.
I could just read through the slide for you. It says environmental risk factors, geographic location, low vitamin D, tobacco use, and infections would be.
Right, here we go. I'm back.
Oh, good.
Wait. Aha. Back. Sorry. These are the times that I really miss San Francisco. I have dead zones in my house for internet as well as my phone. And we may or may not have a spirit afoot. So environmental risk factors, geographic location, the closer you are to the equator, the lower your risk is for MS. And then, of course, there are pockets of exceptions. Low vitamin D is a risk factor, and that might be why. The farther you get from the equator, the more the risk the risk for MS increases. That may be due to not just geography, but geography and therefore naturally occurring vitamin D levels. Tobacco use increases the risk for relapse. Infection, so the Epstein-Barr virus that causes mononucleosis, and HSV-8, herpes simplex virus 8. Now, if you've had mono, you probably won't get MS, but if you have MS, you almost certainly will test positive for the Epstein-Barr virus. So if we look at our patients, 99.6 to 99.9% of MS patients test positive for the antibody against the Epstein-Barr virus, meaning exposure. That's pretty powerful. If you look at the general population, people who do not have MS, it's 96%. So it's a really common virus. What that means is most people who get exposed to the virus will not develop MS, but if you have MS, one of my colleagues describes it as almost a prerequisite for multiple sclerosis. So all of these things are risk factors for relapse and multiple sclerosis. Other things, gender. So relapses, women have a higher risk for relapse. Women have a higher risk for relapsing remitting MS, 3.4 to 1 ratio women to men. Interestingly, there's a slight male predominance in primary progressive MS, 1.2 to 1. But tonight we're talking about relapse and risk for relapse. So gender affects risk for relapse. Of note, women are also more likely to heal completely from relapses. So we're more likely to get it. We're more likely to do well with it. Age. As we get older, the risk for relapse decreases. Ethnicity. There are certain ethnicities that are an increased risk for going from clinically isolated syndrome to relapsing remitting MS, or if they have relapsing remitting MS, they have a higher relapse risk or a higher relapse rate. And that includes Hispanics and African Americans. Genetics, family member with MS or with other autoimmune disorders. So all of the things that are risk for conversion from clinically isolated syndrome to clinically definite MS, those are risks for relapses. Risk for MS in general, and risk for higher relapse rate with relapsing MS. There are certain things that are protective against relapses. We tend to think of disease-modifying therapies. That's as the mainstay of decreasing our risk for relapse. Pregnancy decreases the risk for relapse, especially in the third trimester. Unfortunately, when you another thing, vitamin D decreases the risk for relapse that I'll talk about in a minute. But this is risk for relapse due to discontinuation of protective states. So after delivery, a person is at an increased risk for relapse for the following 6 months. And unfortunately, if a person has active MS and discontinues any effective disease-modifying therapy, that person will be at an increased risk for relapse. But certain disease-modifying therapies carry a low but measurable risk for what's called rebound, where MS returns more strongly than previously, and it probably isn't technically MS, it's probably immune reconstitution, but those two medications are natalizumab and fingolimod. So discontinuation of these protective states increases risk for relapse. So, like I mentioned, some people and some relapses are more likely to result in complete recovery. So sensory relapses, visual, optic neuritis, and brainstem, like I described earlier. Less likely to result in complete recovery. Pyramidal, that means motor, so weakness syndromes. Sphincteric, that refers to if you have bowel or bladder incontinence. And really, bladder can be incontinence or inability to empty. Cognitive and then cerebellar relapses, again, are characterized by imbalance, vertigo, falls, etc. So how do we treat a relapse? Well, there's the idea of the tincture of time, and there's pharmacologic intervention. So steroids, and these are not bodybuilding or anabolic steroids. These are anti-inflammatory steroids called glucocorticoids. Those can be taken orally or IV. Acthar gel is a medication that basically stimulates our body to make our own glucocorticoids. And then plasmapheresis, or PLEX, is almost like hemodialysis, but pulls out large proteins. We think it pulls out some of the inflammatory antibodies. And it is really only indicated if a person is having a relapse and doesn't show benefit from the steroids. Let me just say a couple more words about historically, data has suggested that steroids hasten recovery, but don't necessarily change ultimate outcome. There's now data suggesting that there's improved outcome with intervention with steroids as measured by patient-reported outcomes and some based on disability level. Some data based on disability level. Which is better, oral or IV? Well, if you take IV medication, 100% of it reaches your bloodstream. That's called 100% bioavailability. Steroid or glucocorticoids taken orally, the amount that reaches the bloodstream is about 70%, so bioavailability of 70%. The question becomes, do people need more than 70%? And in general, the answer is no. And most data does not show superiority of high-dose IV versus high-dose oral steroids. That being said, anecdotally, patients who fail, not who fail, so accusatory. For the meds fail the patient, not the other way around. For patients who don't get benefit from high-dose oral steroids, often they go on to get benefit from high-dose steroids. Of course, the question becomes, would they have done it on their own anyway? And that's when it's hard to tell without large data sets. Acthar gel takes longer and is very expensive. Yes, I will answer questions if there are questions about it. So in terms of to treat or not to treat, in days of yesteryear, people didn't treat sensory-only syndromes, or people didn't treat unless you were unable to walk. And the thing is that even a quote-unquote mild relapse can have a really significant impact on your daily function and on your anxiety level, your peace of mind. And so for many of my patients, the difference between recovering in 7 days instead of 7 weeks is a really big deal. I'm not saying you have to treat for every relapse. It's a very personal decision that you should navigate with your neurologist. But suffice it to say that there are some good pharmacologic interventions. And then let's talk about things besides the medications we're familiar with. Like when we're healing from anything, really, I can't think of any exceptions, we want to maximize the building blocks of health and of MS health. So we want to encourage sufficient sleep. We want often you may experience a decrease in appetite. You need to eat to heal, and your body will start breaking down muscle to maintain a blood glucose level if you don't eat, and if you don't eat protein. So you need to eat so that you don't lose lean muscle mass. Hydration, I know, can be challenging if you have bladder urgency frequency, but it's very important for healing. And then vitamin D. Vitamin D is really not a vitamin. Vitamin D is a hormone. We put it in the wrong category. Most of our patients have this hormone deficiency. Vitamin D, when it's in the protective serum range of 50 to 70, that's nanograms per deciliter. And if you look at your labs yourself, you'll see it'll say normal range 20 to 100. Well, that may be true, but we have very convergent data that shows that a blood level of 50 to 70 is associated with a decrease in your risk for relapse. Now, I don't have a data set that shows me yet that vitamin D hastens recovery from relapse, but there's very strong data that it's anti-inflammatory and decreases the risk for relapses. In our pediatric population, for every increase of 10 on that vitamin D level, that nanograms per deciliter, for every increase of 10, there's a 32% decrease in relapse risk. So it's as powerful as our platform agents like glutamer acetate and the interferons. When we think of preventing relapses, again, we tend to think of our medications, from our injections to the oral agents to the infusions. There are a few of these medications that are associated with an improvement in your functional status. I'm not talking about relapse recovery right now. I'm just talking about general care. But by and large, most of these are preventative only. Relapse prevention, like I said, includes vitamin D, nutrition. Stress is associated with increased relapse in subsets of patients, and therapeutic community is associated with better health outcomes in MS. Exercise PT, I should probably take off of this slide because we're specifically talking about relapses. I think in general, if you're experiencing a relapse, you actually need to conserve your energy. So in acute relapse, I don't recommend vigorous exercise. But in terms of improving function, ultimately with your MS, how can I do better? I'm taking my MS medication, my disease-modifying therapy, but I don't feel better. The number one strategy is to avoid injury, and that's with disease-modifying therapy, with vitamin D, and the other things that I mentioned. And then we have other levels at which we can intervene. Again, this is not for relapse management. This is for when you're done with the relapse and you're left with symptoms. We do have strategies to help improve your function, and some are in the pipeline still. So in summary, we know that MS has a genetic contribution, but most of it's sporadic. Low vitamin D is a risk factor for MS. It's a risk factor for relapse. Being a woman, unfortunately, is a risk for relapse. And I do want to stress that we are, well, actually, I can't say that we are becoming, I guess what we could say is, as a community, MS folks are doing better than they were 25 years ago. So pre-treatment, pre-vitamin D, pre-emphasis of wellness strategies like nutrition, exercise, stress management, most patients with relapsing MS became progressive by year 10, and that number is now down to 10%. And, of course, we're continuing to follow people to see what percent become progressive at year 15, 20, et cetera. But for now, our initial data looks very promising. Relapses and pseudoexacerbations can have a negative impact on quality of life. And I realize that I really didn't explain very well what pseudo relapses are. as I showed you in the beginning, the MRI that had bright lesions that took up contrast, as I mentioned, those are emblematic of new inflammation. You can have an attack, recover from it, and then when it's hot out, your symptoms can come back, usually not as strong as your first relapse. When you're stressed out, your symptoms could come back. Some people are more sensitive to cold. Classic is that folks have a urinary tract infection and symptoms come out. If we did your imaging, we would not see new inflammation because it's not an exacerbation. It's a pseudo-relapse or a pseudoexacerbation. And those are not treated with steroids. If you have had an MS attack and your symptoms come back, just not as strong, or you feel like they're simmering just under the surface, first thing is I don't want you to panic. I want you to call your physician, your primary or your neurologist, and be evaluated the next day. If they say it's not an emergency, can wait a couple days, say, I attended a webinar and the person said that I should really come in, if nothing else, for a urinalysis. And that's true for men and women. A urinary tract infection, a urologically silent urinary tract infection is the most common cause of pseudo-relapse, meaning that you don't even get the burning or the pain. But when we check your urine, lo and behold, there's a urinary tract infection, and your neurologic symptoms go away when you do a few days of antibiotics. The best treatment for relapses is prevention, and that's true in just about any health arena. That early intervention, the earliest time point being before time point 0, so prevention is the best treatment. The risk factors that I mentioned, there are some risk factors we can change and others we cannot. We can certainly be adherent and take our vitamin D regularly, and then have your neurologist check your vitamin D level. Not everybody can absorb it by taking those little gel caps, and you might be taking 10,000 international units a day, and your level still isn't 50 to 70. If that happens, don't panic. I can't prescribe over the phone, but talk to your neurologist about sublingual drops. It circumvents the GI system, and we should be able to get your level up. So you can get your vitamin D level up. You can modify the stressors in your life. You can modify the way your body handles stress, and that is well achieved not just by medication, but by sleep, nutrition, exercise, meditative arts. So stress management is a modifiable risk factor. If you are a smoker, if you are newly diagnosed, don't quit cold turkey. This will add to your anxiety, but do get out a calendar and make yourself a plan for a slow taper. And if you've had MS for a while, you know what? Actually, anybody who smokes is self-medicating something, and so just be kind to yourself as you're quitting smoking, and recognize that you might feel some feelings that you don't want to feel, like anxiety or depression, and make sure you address those as they come up with your care team. There are interventions, medical, that we can do for relapses. High-dose IV steroids, high-dose oral steroids, Acthar gel, plasmapheresis. As you may have noticed, I have not given specific examples of doses or steroids, and if people want that kind of specific information, I can go into that in Q&A. And that brings us to Q&A. I can see that there are a couple questions here. Before we get to the questions, I just want to say that it looks like quite a few people took the time to tune in this evening, and I just want to say that is, I think that information helps allay anxiety and gives you some tools to have action plans at your baseline and crisis plan. And for a lot of my patients, it's really helpful. So thank you for coming out tonight and investing in that. Also, shout out, I see some familiar names on here, and so it's making me smile seeing those familiar names. And then lastly, I want to thank the MSAA. What I can tell you is the different support groups, the different advocacy groups, support groups for our MS patients, all provide really wonderful resources. The MSAA really delivers. And if you're ever thinking, I don't know what the first steps are to get an electric wheelchair, I can't afford my MRI. If there's anything that you kind of feel lost, call the MSAA. They really deliver. And don't spend money on any device without checking with them, because they're so helpful with so many of the devices. The MRI program, they can help with brain and C-spine MRI now. Correct me if I'm wrong, but last I heard, they got phased back in. And then regarding tonight, the Relapse Toolkit is, if you haven't taken a look at it, take a look at it, because it's a nice resource. And if you forget some of the things we talked about tonight, I believe this will be posted there if you want to look at the slides, or they also have other resources that I really like how they're organized. I think it's a really helpful tool. So thank you to the MSAA, and then we can take questions. I think someone was going to kind of moderate them and choose which ones we talk about first.
Right. This is Peter. Well, thank you so much for the nice compliments and kind words for MSAA, and we appreciate that. And we certainly also echo your sentiments about appreciating everybody that tuned in tonight, and certainly was very active, typing in a lot of questions in that chat feature. And so I was doing my best while you were presenting to jot them down and try to organize them. And I know you kind of touched on this in the last slide about pseudoexacerbations and trying to know when things occur, but we had a couple questions really around the timing of things, around when do we know we are having a relapse, and when do we know when the relapse is actually over?
Interesting question. So, very good question. Sometimes it's really obvious that you're having a relapse. So you have noticeable weakness in one of your limbs, or you have really obvious numbness in one of your limbs that you haven't experienced before. So new focal, meaning affecting a specific area. So not, you know how when right before you get a viral illness and you kind of feel weak all over, that's called generalized weakness. This is different. This is called focal weakness. So one arm, one leg, or both legs, or one side, an arm and a leg, but not full body. So focal numbness or weakness, especially in a distribution, so in areas that you haven't experienced before. Historically, a relapse was considered when symptoms lasted for more than a day or so. But really, you probably know hours into it if something's abnormal in certain situations. Sometimes it's not that clear. In fact, sometimes my patients who have really active MRI scans aren't that symptomatic. I've had patients just feel fatigued or just feel spacey. Now, I don't want you to go and get in the scanner every time you feel fatigued or spacey, but what I'm trying to highlight is that it isn't always straightforward. It is straightforward if you have new symptoms that affect a specific part of your body, or if one of your eyes is blurry with pain behind it and reds look like orange and it hurts when you move your eye, or you're seeing double or images are stacked one on top of the other. Those are some obvious symptoms that really, if you experience them for the first time, it's probably a relapse. In terms of pseudoexacerbation, by definition, it's a re-expression of old symptoms. So it's that you've had a relapse before, and now you're having similar symptoms, but not as severe. Sometimes you'll get to know your MS, and you'll be like, I must be more stressed than I realized because my feet are numb again. Or you might realize, you know what? It's not just heat that I'm sensitive to. I'm sensitive to cold also. And now my window at which I don't have symptoms has gotten more narrow. So you'll learn these things about your symptoms and what causes them to increase. In terms of when should you call your doctor, a lot of MS specialists will say there aren't real emergencies in MS and you can always wait until the next morning. And I would say that's kind of reductionistic. I mean, it's true that nothing is going to kill you or land you in the ICU, but there's something about neurologic symptoms that it's different from a sore throat. It can be very anxiety-producing, unsettling. It provokes a lot of fear, right? And so that kind of suffering, I think, warrants evaluation by a doctor. You don't have to go into the ER, but don't be shy about calling the nurse at your MS center. For anyone who's on the line who has MS and is not followed at an MS center by an MS specialist, you don't have to come and see me in New Orleans, but you should see someone who specializes in MS at least once a year to maximize your toolkit and to maximize your components of care that I showed with comprehensive care. All of those centers will have a nursing support team for you to call if you're concerned about new symptoms.
Great. Thank you so much. There are a couple questions about specific issues people are dealing with and wanted to know if that was related to a relapse. And the first was, I was recently diagnosed with MS and dealing with debilitating anxiety. Would this be considered a relapse? And then the second question is, does a relapse cause an MS hug?
So let's start with the second one. The MS hug, which sounds like it's cute and furry, but I don't have a single patient who likes it, their MS hug, his, her, or their MS hug. That is associated with a spinal cord lesion, like I described when I mentioned that there can be symptoms that rise up to the level of the torso, and then they're accompanied by a tightening that feels like a belt or a band. That is what's referred to as the MS hug, that tightening that feels like a cinch. Some people have it just around one half of their body, but it's more commonly circumferential around the whole body. It is associated with a spinal cord lesion, and so you may have had a spinal cord syndrome and recovered and then later develop an MS hug. If that is a new symptom for you, make sure that when they image you, they don't just image the brain. That is a spinal cord symptom, and they will not catch it on a brain MRI. So yes, the MS hug can be part of a relapse, and it's part of the spinal cord syndrome. The other question about disabling anxiety, MS is associated with an increased risk for developing depression and anxiety disorders, number one. Number two, MS invokes anxiety. In other words, similar to the way we talk about reactive depression, your spouse dies, it would be odd to not be depressed. In that setting, that's a reactive depression. In the setting of MS, it would be odd not to be anxious. It's like a reactive anxiety. So what you're experiencing is very common. If you feel, and I should add to that steroids are notorious for increasing anxiety. So if you're newly diagnosed, you're on your high-dose steroids, and you're on a prednisone taper, it's a setup for heightened anxiety. If you had a relapse, recovered, and now you're experiencing escalated anxiety in the absence of anything else, classically, that wouldn't be considered a relapse, but my experience has been that people are wired differently, and if it's early enough in your journey with MS, then I would actually recommend having a pretty low threshold for imaging you, because you can have, again, I couldn't point to an MRI and say this is where the anxiety center is, although it's kind of the amygdala. But the point is that anxiety when a person has anxiety, fatigue, or depression, or cognitive challenges, it's representative of inflammation, not necessarily in a specific place when it's part of a relapse. So I know that doesn't exactly answer your question, except for to validate you that anxiety is really common, and that if it's really heightened anxiety and it's episodic and these are your first time anxiety or panic attacks, you should get evaluated. Make sure that your labs are checked. It's really common for the thyroid to get out of whack for our patients, and hyper or hypothyroidism can affect anxiety. Make sure you're and then like I said, I would have a low threshold for imaging if it's early on in your journey and you're still navigating what symptoms mean to you and your MS.
Okay, great response. Is there an age where relapses are less common or frequent?
So in general, yes. As we get older, there's less of an inflammatory response. But what comes up all the time in clinic, understandably so, and therefore it comes up all the time in our clinic conferences, is do people reach an age that we should feel comfortable stopping their therapy? And as we move forward, we will develop tools for precision medicine so that we can test you and tell you on an individual basis, for you, it has your MS run its course and now you're not going to have relapses. What we have now is imprecise medicine, really, which is population-based. So the population as a whole, people over 65 are less likely to have relapses. People over 60 are less likely to have relapses. But all of us in our MS clinic conferences have had patients who have been radiologically stable for decades, and 62, and we take them off therapy, and there's a relapse. So that's anecdotal data to be cautionary, and population-based data to suggest that there's a decreased risk after the age 60, after the age 65, and then just cautionary. It's like everything else in MS, until we have the tools for precision medicine, we have to really emphasize collaborative medicine and work with your neurologist so that we can treat you as an individual and look at all your data as an individual. I do want to answer one of the questions. It was one of the first one about, is there a natural way to prevent relapses without taking disease-modifying therapies? And the answer is yes. And it's maximizing all of the other components of care. And so we have the best data for vitamin D. Like I mentioned, getting your serum level, it's specifically of 25-OH, which is 25-hydroxy vitamin D. Actually, 25-hydroxy vitamin D too. But so we have the best data for vitamin D for decreasing relapses. We have data that modifying stress factors can decrease risk for stress. And we have data that people who are more physically active recover more fully from relapses, which emphasizes the role of exercise. The role of exercise is also, I think, emphasized by the fact that regular exercise can decrease stress levels, which in turn can decrease your risk for relapse. So for all of my patients, I like to maximize vitamin D, stress management, nutrition, exercise, and therapeutic community. I would just say that you should stick to that checklist if you're not on DMT with even more tenacity.
Well, actually, that's a perfect response, because I was going to ask you about the vitamin D question, but you just responded and addressed that, plus the additional activities. So that was great timing and great answer. And I want to advance to the next slide and thank everybody. We are just about to conclude tonight's program, but before we do, I once again want to remind people that our webinar is being recorded, and it will be on MSAA's website soon. And also I wanted to remind everyone about our MS Relapse Toolkit that is also on our website, and you can get that as a PDF download, or you can order a free copy, and you can just go to mymsaa.org, and you can go to the publications section and see that available. And I would like to certainly give a special, wonderful shout-out to Dr. Crabtree for what an amazing job you did tonight, despite some of the technical issues.
Yeah, sorry about that.
No, not
but
at all.
It's my pleasure. And I have to say hi to Randy and Jennifer and Veronica. And sorry if I missed anybody on the list, but I miss you guys. Thanks so much for having me.
Quite a following. That's awesome. And I also want to thank our program supporter, Mellon Pharmaceuticals. As I mentioned before, we have a quick survey at the very end that is coming up next. And once again, thanks to Dr. Crabtree. And on behalf of everyone at MSAA, thank you so much for joining us, and have a great night.
Thanks. Good night, everybody.